morning. We will speak about causal concepts in epidemiology. It's less than an hour lecture, but I hope you sort of get the key things out of the lecture. And the objectives I hope for us to achieve today is to be able to define causation in the context of epidemiology and differentiate between associations and causation, and introduce some causal frameworks, how we make causal inferences, and then along the way we'll discuss applications of the causal concepts in epidemiology or in public health. I have spoken as slowly as I can, right? Taking. Awesome. I have some excellent references for you to look through. These are not necessarily papers, because papers you can find easy. But there are quite some nice books. If you just get one of these books, some of which are available online, you may enjoy reading. So these come from different fields. So one of it is from social sciences, and the other is mainly in the economics, and one is regarding epidemiology. Karma. I think people use the word karma quite often, right? Actually, it's a really nice concept, karma. It's about cause and effect. I think you use it often in a negative way, right? Like karma. But in Buddhism, karma underscores the interconnectedness of actions and outcomes. It's not necessarily that it's bad actions that give you karma. The idea is that you could have personal responsibility and ethical living, at least under Buddhism faith. And by cultivating good karma and reducing harmful actions, individuals can progress to this path of enlightenment. Ultimately, they transcend the cycle of birth, death, rebirth, as you know the Buddhism advocate, and achieve liberation, like your happiness and all. The idea of cause and effect is not new to even a child. It doesn't take long for a child to know that if they touch fire, they get burned. Or if you knock on a door, your mom opens. Or if you cry, you get milk. Like, cause and effect is something we learn from very early on in our lives. The key issue when you're learning cause and effect as a young person is that the thing that causes, or the thing that you get an effect from, the cause is almost immediate after. So you have, I cry, somebody responds to me immediately. Like the concept of time is very close to each other. Or if you turn the switch here, the light comes on. That's our thinking about cause and effect. Yet, the complete causal mechanism is a lot more intricate. So if you take the example of this switch here, I put on the switch, the light comes on, but there are lots more things happening behind. Like you need Kenya power, electricity. The circuit must flow. Your bulb must have the diode or must have the filament that warms up and produces the light. All that is part of the causal mechanism, yet what you think of often is just the switch. Now, the inadequacy of that approach of cause and effect is seen like when the bulb fails. Then you know it's not the switch that puts on the light. There's a lot more into it. So I hope to, in this lecture, help you understand that early conception of causation is a little bit too rudimentary to be applied in real life or in the complexities of epidemiology. And that's the basis of scientific theories. To think a lot more about causation is not just the switch and the bulb, there's a lot more that could be happening in the causal mechanisms. Maybe we should start with a working definition of causation or cause of specific disease. So this would be an event, a condition, or any characteristic that precedes the outcome of interest, without which that outcome will not have occurred at all, or even occur, or would not have occurred until a later date. Under this definition, it may be that there is no specific event, condition, or characteristic that's sufficient to cause or to produce the disease. It's needed, but by itself, it's not sufficient. The switch here is needed, but it's not sufficient. It's a component of what causes light once you switch on. So the sufficient cause then is a complete set of conditions and events that inevitably, once you put them together, then you get that outcome of interest. Basically, the minimal conditions that eventually produce the disease. So again, in the context of the bulb and the light, you need the bulb, you need it to be working, you need a source of power, and you need a switch that, cuts the circuit on and off. All those little components I mentioned is what we refer in epidemiology as component causes, which are the individual elements that, when together, they form the sufficient cause of disease. I should introduce the concept of multi-causality. And the idea here is that most health outcomes and diseases will be caused by multiple factors that need to work together rather than a single cause. So take the example of coronary heart disease, CHD. It's caused by a combination of biological factors. So it could be you need to have hypertension, or you have a genetic predisposition, or you have high levels of bad cholesterol. It could be associated with environmental factors, air pollution, could be out of lifestyle factors, smoking, physical inactivity. So really a person with genetic predisposition for CHD or coronary heart disease, a biological factor, who smokes, that's a behavioral factor, that has a sedentary lifestyle, got into a car, got here and sits the whole day, and lives in a polluted urban environment, is at a significantly higher risk of developing coronary heart disease. Yet, each of these components is not sufficient to cause coronary heart disease, but when together, they increase the risk of getting CHD. Even if one factor, such as smoking, is eliminated, so you stop smoking, the person might still develop coronary heart disease due to the presence of other contributing factors. And if a component cause that is neither necessary or not sufficient is eliminated, you may still see a substantial amount of the disease having been prevented, which makes epidemiology a little bit murky. Thus, you know that one need not identify every component cause to prevent some cases of disease. Now, why this is such an important concept in epidemiology is the ultimate science of epidemiology is about identifying the links between what causes disease and breaking those links for you to improve the health outcomes of individuals and the population. But to think about causation, you need to make judgment as an epidemiologist. So you should be aware and alert about the play of things like bias, confounding, chance, error. And even things like reverse causality. So for instance, if I give you the example, I give you a statement, regular activity reduces the risk of depression. Do you agree? Does regular activity reduce the risk of depression? What would be the possible theory for that? Yes. Name and then answer. And what do endorphins do? Feel good? So you have good moods because of your regular exercise, and therefore you have less likelihood of depression. What might be an alternative explanation to it? Yes, and okay. Name? Maureen, yes. Uh-huh. Okay. I think all those are really plausible reasons why regular physical activity reduces the risk of depression. Do you think about reverse causality? What could depression cause physical inactivity? So which one comes first? If you saw an association between depression and physical activity, you may not tell whether it's actually depression that caused less physical activity or it's physical activity that caused you not to have depression. Like that reverse causality is an important thing that you need to be aware of as an epidemiologist. And then you do need to utilize the causal models to broaden causal perspectives. And I'll give you a few examples of that, some of which are drawn from other fields outside of epidemiology, and the causal criteria that make inferences. So consider these three questions. The first question is, what proportion of patients taking drug X suffered adverse side effects? Second question, which patients taking drug X are more likely to suffer adverse side effects? And that question, would the risk of adverse effects be lower if all patients took drug X instead of drug Y? So I might ask this group here to give me what might be this kind of study design and analysis that you might do to answer question one. What do you think? And if I ask them question one, it means that you guys are answering question two. It means that it's question three. Yes. Name, Cosmos. Do you really need a baseline drug? Okay. Any other thoughts? Yes. So you start with a cohort of people not taking the drug, and then you introduce the drug and see. Yeah? Mm-hmm. Okay. Baru. Okay. I think you like the strength of a cohort study, but essentially would a cohort study just give you incidence? Yet here all I want is a proportion of people who have adverse effects and have taken drug X. So if I came and asked you, are you guys smoking? And you have, like, I would get that answer whether you are like a longitudinal cohort or just cross-sectional, no? Would you not? No? Okay, question 2. Yes.
So I think now question 2 cohort will be better for question 2 because we are looking at which patients taking drug X are more likely to suffer. So the thing is more likely, I'm assuming that the adverse effect has not occurred. So, but we are looking at which ones will end up having these adverse effects are more likely. So we are basically comparing because more likely there is a comparison there.
Okay. Any other thoughts?
I think.
Name?
Purity.
Purity.
So yeah, I think doing a comparative study, including controls, it's more brings assurity.
Okay. Group 3? Yes. A mic is almost your way.
Yes. My name is Alfred Monari. I think logistic regression model, combination of odds ratio can fit that option 3, whereby you have predictor variables on what causes factor effects. Then we categorize it into maybe 0 or 1 to know which one they are the more risk, the riskier ones, which will cause the adverse effects. So I think the logistic and maybe or the odds ratio can fit that one.
Monari is a statistician, so he went straight to. I'll leave that for you to think through once you get the notes. But one of the ideas around epidemiology is the person, time, and place. It's really important. Who has what, where, and when. Yesterday we talked a little bit about the story of Jon Snow. And we were talking about London in the bad times, and he drew the map and showed all the places where there was a death, and had identified that most of the deaths were associated with a pump. Now, the epidemiological understanding of cause and effect does not need to be 100% complete or accurate for you to permit useful application. So like in the case of the story we were referring to yesterday, they had never known at the time that there was vibrio cholerae, which was like identified nearly 40 years later, the actual cause of cholera. But there was some understanding about the causal mechanism and components of that, which included you need to access polluted water, which was the hypothesis that Jon Snow was applying. And by the removal of that one component cause, there was a reduction in the cholera cases, even though there was not complete 100% understanding of the complete causal mechanism. The second example we were looking at yesterday about childbed fever and Semmelweis or puerperal fever, where the clinics where doctors and student doctors were working had higher mortality rates of mothers compared to where midwives were working, is a complex health system issue. So it has layers of causation. There is how healthcare is organized, that you have clinics that have doctors and clinics that have midwives. And you have the behavior of doctors who would go and do autopsies and then come and help mothers give birth. And you had hygiene practices. They never washed their hands, or they did not disinfect well enough by the time they were attending to mothers. The infection routes and infection and control once that was established. Again, At the time, they did not know what was causing puerperal fever. All they did was see components that, once put together, they result in death of mothers. Really a good example as well. There's also like bad examples of when you use causation in the wrong way. Like the story I was giving you about Black Death in the 14th century. That there was a group of people, the Jews, that were persecuted because they were seen to be associated with less disease, and therefore they must be contributing to disease themselves. So once you sort of go wrong on causation, you could end up with really catastrophic actions that do harm than do good. So the idea of causation is so integral within epidemiology that as you make your actions, public health actions, you do need clarity as to what are the causal mechanisms associated with it. So I took like that one example, the risk of adverse effects be lower if all patients took drug X instead of drug Y. The goal here is to make an inference about the distribution of patient outcomes, which the patient outcomes in this case is adverse effects. Now, if all patients had taken drug X versus if the same patient over the same time frame under similar conditions had taken drug Y, then you sort of can make a comparison as to what would be the impact of a choice between drug Y and drug X. At the heart of these decisions, what we want to know about the relationship between exposures and outcomes is, does X result in better health outcomes compared to Y, or should we choose X over Y? That's an important epidemiological question that we always are trying to answer, because we have not, resources are not infinite, so we have to make choices between things. Does X cause Y? That general process of scientific reasoning by which we tease out those causal relationships is what drives a lot of epidemiology, because the idea is to find what are those things that we can manipulate, and when you manipulate, then you end up with better health outcomes at a population level. What you should remember is that it's nearly impossible to make proof. We can associate things, but making proof is really hard. The causation between an exposure and outcome, and that's partly because of the inherent limitations that we have of scientific methods. So for instance, we can observe the same individual. We can never observe the same individual under the same conditions, with and without exposure. Right? You make a choice between you guys are getting exposure and you guys are not getting exposure or the treatment. But you're not the same individuals. You have your own differences. It's really hard to say, Damaris, you are getting the exposure and not getting the exposure at the same time under similar conditions. That's a limitation of scientific methods. The second is that we can never observe the same individual at the same time with and without the exposure. Like there is a difference in time. You could start with no exposure, then we have you with exposure, but never the two of them at the same time. And that means that there could be conditions that are happening now that you not have when the exposure is introduced. Again, that's a limitation of science. And we can never observe the same individual at the same time with and without the outcome. So even the outcome that is of interest, again, you either have cancer or you have no cancer. We can't observe you with cancer and without cancer at the same time. So then those associations that you see may arise from things like confounding factors, and those are factors that affect both exposure and outcome, or there could be bias, and this could be systematic errors that you introduce by your choice of design. Like the three questions I was asking you, you had like three different cross-sectional, longitudinal kind of designs, and each of those have their own limitations. Or even chance, random variability in the way we collect data. If I give you a tape measure to measure the size of my head, some of you measure with an extra 2 centimeters, and others will measure with minus 1 centimeter of the truth. And that sampling error or chance or random variability, all those are all important in making it really difficult to prove causality. So in epidemiology, given those difficulties, what we do is form some framework for causal inference. And we borrow from different places. So I refer you to a really nice chapter here called Tutorial on Causal Inference. I have heard from Wema that you're all learning R. So actually, this is done in R, so you sort of can make your attempts on that. And the idea is that you start with framing a question, like a really good scientific question that maybe in this case, that may be related to the timing of when you give ARVs, and then you want to look at outcomes of HIV positive individuals. And the question might be something like, what is the impact of initiating antiretroviral therapy within, say, 1 month of diagnosis on a 5-year all-cause mortality among adults that have recently been diagnosed with HIV in Kenya? You start with a question. Then you need to specify your thinking, or at least the information you have from all the knowledge you have got to frame a causal model. And here you are specifying the causal relationships between, say, variables and the relationships with outcomes. And you summarize this existing knowledge, including in a diagram. So the key idea here is you want to distinguish between what is causal and what is non-causal. So let me give you the example of these 5, 6 diagrams. So take diagram A, where you have got A to Y. And in this case, we are saying you've got an exposure A that directly affects outcome Y. That's easy, right? Switch on the thing, you get the light. Even though there may be other things behind, like you have a very clear connection between exposure and outcome. In the context of B here, you have an exposure A that directly affects outcome Y, and also indirectly affects something that's a mediator, which is a Z here. So when you're sort of making a comparison between exposure and outcome for causality, you need previous information about what might be contributing how. So it could be a direct connection, or it could be a direct connection, and in addition to it, there's a mediator. Or you take the example of C, where exposure A has no direct effect on outcome Y, but is associated, its association is induced by a measured common thing, like what is given here, W. And this thing could be measured or unmeasured, like in this case of D here. Another example here could be, in E, you have the exposure that has no effect on outcome Y. So A has no connection with outcome Y, but its association is induced by only examining, say, a group of people that have a certain thing. So take the example of you want to look at cancer, and you're only looking at people who smoke. So you have actually removed a whole complete group of people who don't smoke. That's what you mean by like a censored. Or it's a lot more complex, that all those factors are not that easy with just 2 arrows, that they're all really complicated. And still, in epidemiology, you do need to tease out these bits for you to have action. Fizzy drinks and old age. What do you think is the association between fizzy drinks and old age? I thought to myself, my grandmother is 98 years old. I must have a chance of showing her off to you. That's my grandma. Still drinks Coca-Cola, nearly 100 years old now. Let's take the example of does smoking cause lung cancer? Does it? Huh? There's an association between smoking. So have they banned the smoking all over here that you can't smoke in public, you can only go in small places? What's the complexity of the linkages between smoking and lung cancer? Why is it difficult to make that causation link? Julia of Shah.
The mighty Shah. Thank you. Because we have documented evidence of people who do not smoke, are not even exposed to people who are smoking but have lung cancer.
Exactly. So there's a great argument against the smoking cancer hypothesis. And at the time before we made this belief as a society that there's a connection between smoking and cancer, the possible existence of unmeasured factors that cause both craving for nicotine and lung cancer. One might say that the person who smokes because they have got something in them that craves for nicotine, and that something in them that craves for nicotine is what causes cancer. Would you refute that? It's an alternative hypothesis to the connection between smoking and cancer. And as Julia said, there are many people who smoke all their lives and never get lung cancer. Like my grandmother taking Coca-Cola, even though 2 of her children have actually died of cancer at a young age. Like these differences in variation make epidemiology murky. Others get lung cancer without ever lighting a cigarette, or as Julia said, even being a passive smoker. So none of anybody around them ever smokes, but they still do get lung cancer. So the way that we might be able to get closer to causation would be perhaps conducting a randomized controlled trial, where you make Monari smoke, and then we make Cosmas never to smoke. But why would that not be something we would be able to do? Ethics. You're right. So for many years, in the 40s and earlier before, once smoking became really cool, there were lots of argument about should we make a connection between smoking, should we stop it or not. And the breach of the stalemate as to whether cancer and smoking are connected was actually broken by the US Surgeon General in 1964's report that declared that cigarette smoking was causally related to lung cancer in men. And even though he claimed causality, it was a bold political move because they actually had used just a qualitative criteria after a statistician called Braddon Hill, and that's what I think you call Hill criteria for causality, which we'll discuss in a short while. And the Hill criteria for causality has 9 components. The first component is there ought to be a strength of association between the exposure and the outcome. So the stronger the relationship between the independent variable and the dependent variable, the less likely it is that the relationship is due to chance or an extraneous variable. So to give the example of smoking, the lung cancer rates for smokers was quite a bit higher than that for non-smokers. So if you look at data, those that smoke have higher chances of cancer than those that do not smoke. The second criteria is temporality. So one thing must come before the other. The exposure needs to come before the outcome. In the case of smoking, smoking in the vast majority of cases preceded the onset of lung cancer. So one thing, like light doesn't come before the switch, right? Like you switch on and the light comes. Then there's consistency. If the circuit and the bulbs are working in each of all the rooms in these UON towers, anytime you switch on, lights will come. In a majority of cases, in consistency, causal framework, you're saying that should this happen or should this exposure be, then you'll see this effect outcome. So like in the case of smoking, different methods, whether you're looking at case controls, prospective studies, produce the same result. The relationship also appeared for different kinds of people, whether you're talking about males and females. Consistency. The fourth is there ought to be some theoretical plausibility that it is easier to accept an association as causal where there is a rational or theoretical basis for such a conclusion. So the biological theory for smoking causing tissue damage of the lungs, which over time results in cancerous cells, is actually a plausible connection. Then there's coherence, specificity in causes. So like lung cancer is best predicted by incidence of smoking than almost anything else. Dose-response relationships. So if I smoke 2 cigarettes and you smoke 15 cigarettes, then you have a higher risk of getting cancer than I do. And then there's experimental evidence. So they had taken some mice and give them tar, and then they found that the cancerous cells of the lungs became cancerous. So there was experimental work, with mice showing that tar is associated with risk of cancer. And then there's analogy. Sometimes a commonly accepted phenomena in one area can be applied to another area. And that's the analogy of like if laboratory rats are getting it, then that should possibly be a causal relationship. But the strength of association is not sufficient because strong associations, you'd expect them to be more likely causal than weak associations, and weak associations are likely to be explained by, say, undetected biases. But I give you this example here. Smoking is actually weakly associated with cardiovascular disease. Why would that be? Why do you think smoking would be weakly associated with cardiovascular disease? Julia, your hand is up again.
Because the way cardiac disease has been presented, the other causes are more louder and more common, like obesity, your diet, your lifestyle. So smoking comes in, but not at the topmost etiological cause of cardiovascular disease. But association has shown that it is also one of the causes that leads to cardiovascular disease.
Great. That's a really good point. And if cardiovascular disease is very common, then the effect of smoking will be seen less and less. Whereas if a health outcome or health event is rare, then the people that have this potential exposure, that exposure will be seen as having a big effect. Now, take the second example here, that birth rank, or when a child is born compared to their siblings, is strongly associated with Down syndrome, like a really strong association. That's a counterexample. Why would that be? Does that mean that birth rank is responsible for Down syndrome? Does it cause it? Yes? Brian is exercising.
The issue of birth rank and Down syndrome is associated with birth rank and Down syndrome is mostly associated with the age of the parents. Yeah, because it's mostly experienced in parents who give birth while they are at an advanced age.
That's such a good answer, because if you account for the age of the mother, then there is absolutely nothing about birth rank and Down syndrome. And the father. Is there a relationship with the father as well? Okay. I'll read into that. So strong association is neither necessary nor sufficient for causality, nor is weakness necessary or sufficient for absence of causality. That's why like the Hill's criteria is not a single criteria. It's a combination of all those criteria for you to draw anywhere close to saying causality. Take the example of this nice figure looking at per capita cigarette consumption and lung cancer mortality among men in the US. So on the x-axis here is time from 1900 to 2010. And on the y-axis, you have got per capita number of cigarettes smoked per year. The thick black line is showing you the per capita cigarette consumption, like the more cigarettes that you consume as a population. And the one that is on the light gray is lung and bronchus cancer. What might have been alternative explanations to this? There's a clear relationship between the higher the per capita consumption of cigarettes, the higher the lung cancer cases. But this was not, even though this graphic is shown, like there are lots of argument about alternative hypotheses to this kind of pattern. What do you think that might be? If you were to argue that there's no connection between lung cancer and smoking, per capita smoking, what arguments would you give for this? You can tell that in the 20s, lots more people are smoking. As you go up to the 50s, and then you have got lung cancer going up. Then you have got the Surgeon General report that happens in 1964, and after that you see less and less of per capita smoking and less of cancer. But at this point, people are arguing that there is really no connection. Why do you think that's so? Any alternative explanation? Think about the 40s. What's happened in the 40s? World War II. Yeah, that's one. Anything else? Actually, a lot of the argument at the time, you know, the motor vehicles started when? When did we start proper manufacturing of vehicles? Ford started this company which years? Brian must know this. There were no Mazdas at the time. But this is like a nice time when motorized mobility is really going up in the 20s, in the 30s. So there's lots of argument that actually all this business about higher cancers is because now you have tarmac roads, and those tarmac roads, the tar might be causing it. It could be that people are now driving more and you're smoking more from the vehicles so it's not necessarily smoking. It's ridiculous when people want to discredit something. Yeah? Like you have seen people discrediting vaccines. People have all kinds of reasons, even when it's not causal, right? Like you say vaccines causes this. But I hope as epidemiologists you understand to make that connection is a lot harder work than just saying Bill Gates hates us, right? So the time series data is good, but it does not necessarily tell us it's not very good evidence for causality. So there was lots of work around Hill criteria. And Hill, this gentleman was a chief statistician, Monari home ground, and had conducted a highly successful RCT that had proved that there was streptomycin as an effective treatment for tuberculosis. And in 1948, Tim and a gentleman called Richard Doll studied the causes of cancer epidemic, and because it was not possible to do a randomized control trial for ethical reasons, as you mentioned, they chose to compare patients that had already been diagnosed with cancer cases. So you're looking at those who have got cancer cases and their controls of health volunteers. And each group was interviewed on their past behaviors and medical histories. The people who were interviewing them were not told who had cancer or who had no cancer, obviously to make sure there is no bias in recording. And the result of that was that out of the 649 cases, only 2 had not been smokers. And the odds are ridiculous. Monari, what does it mean to have an odds of 1.5 million to 1? Yeah? And then it's high above 1? But this is 1.5 million times. And why is a case control study an improvement over the time series data? So I was showing you the time series data, then I showed you the case control data. Why would that be a potential improvement towards causality? Yeah?
I think with time series data is subjected to a lot of confounders because things change over time, and so your exposure is likely to be interfered with.
And the case control?
You may not need to wait for a longer time before you can conduct a full analysis.
So you're right, partly, because when you're doing like a case control, here you are controlling for confounders. You can make a choice between I want to look at males or I want to look at females, I want to look at people of 19 to 25 years, or I want people who only live in a certain near polluting factory. So if you make people look alike as best as you can, then the likelihood of treatment having an effect, your ability to see that effect is much better than when you have all these other confounders within your experiments. But what would be the drawbacks of case control study design in determining causality? What do you think might be the drawback? We highly recommend that once you walk in the morning, take a cup of coffee and tea. Great. There are lots of drawbacks of case control. First of all, it is retrospective. Essentially, the data tells us the probability that the cancer patient is a smoker, and not the probability that a smoker will get cancer. You get that? You're looking at what has happened before. These are case and control right now. What I'm getting more is what's the probability that that cancer patient is a smoker, not the probability that a smoker will get cancer. And in fact, if you are looking at this data, you'd be interested in making a decision as to whether you want to be a smoker or not a smoker. Yeah? Then there's a recall bias. Although Dole and Hill blinded the interviewers, they weren't told who is a smoker or who has cancer and who does not have cancer. Those that have cancer are possibly much more likely to remember smoking than those that don't. Like you question yourself, am I having cancer? Is it the smoking I did when I was 15? Whereas when you have no cancer, that kind of recall bias might not be an issue for you. Then obviously the selection bias, the cases that were patients at a hospital, so hospitalized cancer patients are not necessarily representative of what's happening in the population. So Dole and Hill findings were suggestive, but were never proof of that smoking causes cancer. So after dismissing all those several confounders, they asserted, in fact, if you look at this statement, it's like an attempt to convince that smoking is a factor, an important factor. They are trying even to make an emphasis in the production of lung cancer. It's not that it's a cause of cancer. It's an important factor. Now, there were 19 more case control studies that were conducted in the 50s and the 60s, all which supported the smoking cancer hypothesis. But there was an issue because one of the guys who was a famous statistician, Fisher, who statisticians like to talk about the Fisher test and all, was consulting for a tobacco company. So he had conflicts of interest. Such a strong voice with conflicts of interest. So he kept refuting that evidence that keep coming up. And one statement he was making, like repeating a biased study for 19 times does not make it unbiased. They're just mere repetitions of evidence of the same kind. But these guys were really hard. They wanted to still show that there's a connection between smoking and cancer. And so they started a new study, which is a prospective study of about 60,000 British doctors. And they wanted to get information about their smoking habits. And the data they got out of these 60,000 doctors was that in 5 years, all the heavy smokers, basically, number of cigarettes smoked per day, were found to be 25 times more likely to die of lung cancer than the non-smokers. And then they showed that those that were smoking and then stopped smoking, their risk of lung cancer was actually halved or reduced by a factor of 2. Still, there was criticism for that study as well. The study had not compared smokers to otherwise identical non-smokers, and smokers were self-selecting. They are more likely to take risks. Those smoke that also possibly drink. Are there people who smoke that don't drink? They are. Over where? Possibly are genetically different from non-smokers. So to arrive at that big 1964 report, what they did is they formed a committee that had little conflicts, the best they could. So they put 5 smokers in the room, 5 non-smokers, and 2 people that were nominated by the tobacco industry that had obviously great interests in the findings of this. The people who were excluded were the likes of Fisher and anyone else who had made public comments about the association between smoking, whether they were for smoking causing cancer or they were against smoking causing cancer. Those very strong voices were omitted in this committee that was reviewing evidence. So they sat, and then they used this criteria, again borrowed from Hill's criteria, look at consistency, that there were many studies in different populations that showed similar results, that there was a strength of association, including the dose-response effect, that more smoking was associated with likelihood of getting lung cancer. There was specificity of association, that there's a particular agent that could have a particular effect and not a long litany of effects. I think like the coronary heart disease stuff that we're discussing. There was a temporal relationship that lung cancer comes after smoking, and then there's coherence, which is the biological plausibility and consistency with other types of evidence that were created, say the use of rats in the laboratory. And this is exactly what you get faced with as an epidemiologist. That you will not have this very clear-cut thing of A causes B, like you need multiple evidence lines for you to institute public health actions. And then you ought to be aware, like, after that, there was some work done in the 50s, in the late 50s, looking at smoking and birth weight, and that's what is called the smoking birth weight paradox. And what they found is this gentleman, Jacob, he launched a long-term study that was collecting pre- and postnatal data on over 15,000 children in the US, in San Francisco Bay Area. And they collected data on smoking habits of mothers, birth weights, and mortality rates of children. And prior studies had showed that death rates of low birth weights, children or infants, was up to 20 times higher than the normal birth weight infants. And therefore, you could make a causal relationship that says smoking leads to low birth weight. Low birth weight leads to higher risk of mortality among infants of smoking mothers. But the study had really surprising results, that low birth weight babies of smoking mothers had a better survival rate than those of non-smokers. So if you're born as a low birth weight child and your mother was a smoker, you have better survival than if you're born of low birth weight and your mother was not a smoker. What might explain that? A baby born of a mother who is a smoker with low birth weight has better survival rates than a baby born of a mother, a low birth weight baby born of a mother who is a non-smoker. What might be the explanation for that? It's a paradox, right? Anyone? Yes.
I would say, is it even loud? Okay. I tend to think the choice of exposure there was wrong. This man would have studied other exposures potentially. But what I would say is that there are other things, other factors that affect or that influence a baby's well-being other than smoking. Yeah.
But those factors would still be true for babies born out of non-smokers and smokers.
Sure. Let me think again.
All right, think again. There's one at the back there.
I'm doing a trial. My thinking basis being on the biological aspect. Oh, sorry. Oh, my name is Kendi. I'm doing a thinking on the biological aspect, whereby the babies that were born low weight, but the mothers were smokers, were exposed to harsh conditions already while still the development, compared to the non-smoking and the low weight, whereby the low weight of the non-smokers got to get a higher chance of survival than the non-smokers' low weight babies. Thank you.
Great. One final one here. Every attempt is valid.
I'm just thinking maybe there was a bias in the way the babies were being treated. For those who were born of smoking mothers, they were given more attention than
The health
those who were
system
not.
is here. Great. Well, the birth weight paradox is well known because low birth weight of a baby could be explained by one or two factors. So the first is that a baby could be low birth weight because the mother was a smoker. But also it might be affected by other factors, maybe a serious life-threatening illness that affects the baby's survival. So then if the mother does not smoke, there is stronger evidence that the cause of low birth weight in the mother that does not smoke child is possibly a birth defect. And a birth defect would mean a worse prognosis for the baby. Make sense? Like you have sampled low birth weight children. If the cause of low birth weight is smoking, it's better off than if the cause is a genetic birth defect. So if you observe among low birth weight children, the ones that have a smoking mother, it's bad, but it's not as bad as if you have a genetic disorder, because then the genetic problem could lead to higher mortality rates, and that was the reason for that birth weight paradox. As you think through causality, you have to think about treatment effects, whether the treatment effects that you're observing are of the average treatment effects or the individual treatment effects. Whether my grandmother takes Coca-Cola, like that's an individual treatment effect, that's what she does. But on average, Coca-Cola is not good for you, or fizzy drinks may not be good for you for old age. So you sort of have to think through what are you measuring as part of your studies. The real question we are asking always is an intervention effective? So the treatment effect we get is almost entirely determined by the source of treatment variation we use. That's why you try and do randomized control trials to make sure that you have a group that receives treatment that has almost similar conditions to the group that does not receive treatment, and the only thing that you're varying here is the treatment, whether or not you get a vaccine of the same people. And then you sort of have to average those to say, well, vaccination protects 80% of the population from getting new influenza once it pops in. So what happens if our RCT sample isn't very representative? RCT here is randomized control trial sample, isn't very representative of the broader population, then you are making statements about a really specific population. So in the choice of who is in your study, it's really critical if you want to make a general statement. If you are biased in your selection, then that is only applicable for the group that you selected from. And that is referred to as conditional average treatment effect. So there are lots of treatment effects that you should learn along the way, particularly when you look at the different study designs, which I hope we can cover in our lectures. But I do want to end that you have to think through what you know and the relationship between variables. You have staff treatment outcomes. That's almost always what you're trying to look at. And it's not always that straightforward. It could be a lot more complex. And you need to have all these causal diagrams based on your previous knowledge to identify what are these things that I make a connection between outcomes and exposures. In summary, as an epidemiologist, you should hold the attitude that all judgment of cause and effect is tentative. You need to have that intellectual humility. Because what you have made a hypothesis, you have some data that directs you to a certain relationship between an exposure and an effect, but there could be other factors that you had not control for or new information that comes through. But causal thinking demands that you make a judgment. Have you eliminated chance, error, bias? Have you considered confounding and reverse causality, like the examples I gave you? Have you used causal models to broaden your causal perspective, like the Hill criteria I provided, to make those inferences? The ultimate science of epidemiology is to break the links between the exposures and disease. Once you break that, then you end up with increased or improved health, public health. And the last statement I want to make, be careful, because misapplication of causality can lead to a lot of harmful consequences and misunderstanding of the world around us. Case in point is the issues of, say, vaccination and autism, if you have heard about it. One little study in the 1999 has caused a lot of vaccine hesitancy around the world for many years. Misapplication of causality. I'd like to end there. Any question? Thank you. Yes. Masafu, yeah.
Okay, good morning, Prof. So that was a really nice, exciting presentation. Okay. My name is Brian Masafu, and I'm just curious to understand how, I don't know if this one stretches beyond epidemiology, but now how birth rank is more associated to mutation, especially based on maybe maternal age and paternal age, maybe, or versus the number of siblings that is born.
How it's associated with?
Mutation.
Mutations?
In the born child.
Okay, you're making a hypothesis that mutations and birth rank are associated.
Yes, because for instance, you've mentioned the Down syndrome problem, which is just a fact of mutation. And I'm assuming that maybe in one way or the other, mutation, birth rank might have an association with now mutation. Because let's say child born when the mother is 60s or let's say 40s might have a higher risk of actually getting some genetic variants from the mother which have undergone some mutation.
Great. I think the point I was trying to make using that example is if at the face of it, you took children with Down syndrome and children without Down syndrome and look at the birth rank, you would see an association between birth rank with the likelihood of Down syndrome, which, as you are putting it, biochemistry is like mutations. Now the point is, it is not so much the variable birth rank, is that the variable birth rank in it contains the age of the mother. Like the birth rank, the higher the birth rank, the higher the likelihood of getting a baby when you're much older. Yeah? And that getting a baby when you're much older then could increase the risk of like those kind of mutations. So the idea was like, don't just take things at face value, like think through what might be the causal mechanism or alternative explanations for why you might see an association between birth rank and Down syndrome. Yes.
Thank you so much, Dr. for the presentation. Mine is a small concern. When you find that your study has multiple causes, you mentioned it's multi-causality, and then at some point it also overlaps with some of your confounding factors. Yeah, how can you try to balance or differentiate?
Yeah, I think that's the point I was trying to make, that like prior knowledge is really important information of what becomes your analysis. Like spending time to come up with a causal web of potential causality, given the different information you have biologically or socially or environmentally, is really important for you to tease out so as confounders don't overlap, just sort of to increase your strength of evidence towards causality. Also do remember I said it's almost impossible to make proof because we already have got lots of limitations in our scientific methods. But put together, we have very strong evidence to have action because you don't need 100% complete understanding of a system to actually manipulate it. Soma. All right. Last one, yeah?
Okay, I'm sorry, but just on her question, maybe you are involved in a study that does not have maybe prior knowledge, that you are trying to come up with your own prior values. Let's say you want to formulate a posterior based on unknown prior values. So how do you go about it?
George is very happy. You want to answer that? Go ahead.
Okay, let me put it this way. So the question is asking, he's going Bayesian, and I normally don't focus on the tool you're using or the method you're using. Focus on the question. A well-formulated question is half a problem solved. If your aim, he's given a very good example of like the Down syndrome and birth rank. If you're going to formulate your question as, does birth rank lead to Down syndrome? It sounds a very simple question, but then going to answer it becomes a problem. I normally give people an example of, I did a study in Masai Mara as a student, and my question was, does social culture lead to cases of tuberculosis in a household? That question sounds intelligent right now, but back then it sounded intelligent. But the more I look at it, the more I realized there were a lot of things I was missing in that particular question. You're getting? So even if I was to do Bayesian and I'm supposed to create a prior, there are ways in which you can create priors. And I think in one, I can show an example later on, and in which you work through a prior. There are ways in which we choose prior. Let's say, for instance, if we are comparing tests, we can choose a prior based on certain stuff that we have. So when you're formulating a question, the best way is to start with formulating the best question and thinking around it. I normally insist on a student drawing a diagram. When you draw a diagram, then you're able to start thinking through some of the other stuff. And then you choose the appropriate analytical tool. You don't start with choosing an analysis, like you want to do a Bayesian analysis, for instance, or you want to go and do like a multinomial analysis, and then try and fit your question onto that. You start with the question, and then let the data guide you in terms of like what are some of the potential analytical tools I can use on this. Remember, all these things are tools to answer a question. So the question is actually much more important.
Okay, good morning, everyone. Okay, so who has ever attended training at SEMA before? Please put up your hands, like, so I can really see. Okay. Who has ever had my lecture on study design? Joy, put up your hand. Cosmos. Joy, you've never had it? Anyone else? Okay. So don't give them the answers, eh?